And next we have Jessica Erkman. So there's nothing that quite says a rare disease patient organization leadership role than a mom in the hospital with her daughter, which was me with Josie in February, learning from Jessica, what was going on with Josie's breathing, why her lung capacity was so low. And the way she was explaining it to me, I was like, hold on one second. Would you come to our conference?
She did. She really did.
Thank you so much for saying yes and helping Josie.
It's a pleasure to be here. Thank you. So I'm Jessica Erkman. I work at NYU, Hassenfeld Children's Hospital in New York City. I wear many hats. I'm a pediatric pulmonary nurse practitioner. I also am the clinical coordinator and NP for our aerodigestive program. And I have also been trained in ear, nose, and throat, as well as GI. So the whole tract from the nose down. So potential problems in children with FOXG1. And I say potential because we know that there is a range of spectrum and phenotypes here. So in terms of the respiratory system, when children with FOXG1 have neuromuscular weakness, when they have that hypotonia, there's a greater risk for them to have respiratory issues. And those can include both upper and airway obstruction syndromes, chest deformities, weak cough, or what I prefer to call ineffective cough, impaired mucociliary clearance, so impaired ability to get the mucus out, recurrent lower respiratory tract infections, aspiration, obstructive sleep apnea, and hypoventilation. So when the muscles are weak, and I'm going to flip back and forth between two slides to show you pictures, what happens when we breathe in, we use many muscles to expand our chest wall and to push down the diaphragm. And this allows the lungs to open up and to get all the air in that we need. And then as we breathe out, we have what's called elastic recoil of those muscles, and they also contract to really empty our lungs and clear everything out, the air, the mucus, anything that doesn't belong there. So when those muscles are weak, several things happen. One, your chest wall doesn't comply as well. And you start to develop scoliosis because our muscles are also responsible for keeping our spine aligned and keeping all those rib muscles aligned. And as you see, in a child with neuromuscular weakness, when that rib cage starts to get deformed because the spine is curved, it starts distorting the airway. And when these muscles are weak, and we don't have that expansion and contractibility, we lose that elastic recoil, we start to have lower lung volumes. So on the right here, this is a normal lung with full lung volumes and a normal chest wall. In children with neuromuscular weakness, they start to lose lung volume and the lung becomes much smaller. When you have low lung volumes, you then start to hypoventilate. You're not breathing as deeply and as well as you should be. And when you're not expanding your lungs completely, the lower lobes of your lungs start to collapse. And when they collapse and air is not getting there, the mucus becomes trapped and it starts to thicken and you end up with mucus plugging that we call atelectasis. And left untreated, this then develops into bronchiectasis, which is where the breathing tubes, the bronchial tubes, become inflamed and they start to scar. And then that progresses ultimately into what we call chronic respiratory failure. You also have a neurological component to this. So children with cerebral malformations and neurological impairment and recurrent and seizures have lower sensitivity to CO2. So when we breathe in, we are trying to get oxygen to our body. And when we breathe out, we're trying to breathe out what we like to call the bad gas, the CO2, the carbon dioxide. CO2 is a chemical receptor in our body that is also used to help regulate our breathing. And so when your sensitivity to CO2 goes down, then you tend, particularly in sleep, to have more hypoventilation. And you can develop sleep apneas, central events, and obstructive sleep apnea. And when those are left untreated, they also progress to chronic respiratory failure. So in terms of upper airway obstruction, many people, even children who do not have neurological impairment, can have some elements of upper airway obstruction. Your adenoids, which I like to consider like the tonsil in the back of the nose, can be large and obstruct the airway. The tonsils can also be large. But then when you compound this with the muscle weakness, what happens when we sleep? When we all sleep, our muscles all relax. And so for you and I, when we have a normal airway and our muscles relax a little bit when we sleep, there's still plenty of room there that we're breathing when we sleep, and it's not a problem. But if you're starting out with some muscle weakness, and then when you go to sleep at night and it's collapsing, then you get obstruction, and very often noise, and not just snoring, but a lot of these children will have gasping, this sort of noise that they'll do in their sleep, or they'll sleep with their mouth wide open. The walls, So the walls of the airway, so that's your epiglottis, and black, you can think of black as air, right? So here's your airway. And so these children very often have what we call pharyngeal collapse. When they're sleeping at night, this is done during a sleep laryngoscopy, which I'll explain. The walls are completely collapsing, and you see how you lose the airway. And this is at the end of the full inspiration. There's no airway. And so this child has significant sleep apnea. The other thing that can happen is further down. These structures here are your arytenoid cartilages, and what they do is they're kind of like the structures that help your vocal cords open and close. So when we breathe, our vocal cords should open up, and as you breathe out, they kind of close behind the air. These tend to be bulky and weak in children with neuromuscular weakness. So instead, when they're sleeping at night, instead of these arytenoid cartilages helping the airway open up, they collapse in, and you get this when they're sleeping. And very often they can even have this noise when they're awake during the day. So how do we assess these things? You know, the history that your clinicians take is very, very important. Laryngoscopy, this can be done in the office, which is more like a screening because, you know, putting a little camera in the nose, not the most comfortable thing. Your child's never happy about it. It can kind of give us an idea of what's going on. But what we really prefer to do when we see something or there's symptoms that we're concerned about is what we call DICE, a drug-induced sleep laryngoscopy, where we do this under anesthesia, but they're really just given a whiff of anesthesia to make them comfortable so that we get a real sense, we induce sleep, and get a real sense of what's going on in the airway and where all the levels of obstruction are. So we can decide what is it that we can do to improve the breathing. Is it that sleep study is very, very important in these children? Pulmonary function testing. Now this is challenging in a neurotypical kid. I see many of them, believe me. But there are some children who have enough cognitive ability and muscle ability to do what we call MIPS and MEPS, and it's a fancy short term for a cough test, where we can really assess how effective that cough is. Because we know below a certain threshold that they may still have a cough, but that cough isn't effective enough to actually move the mucus out of the airway. And that's when we want to intervene. We can monitor that CO2. We have a nice little fancy handheld device in the office with a little mask, and we can get a measurement. Is that measurement too high? And do we need to think about other testing? And we can also measure the CO2 in the blood. So if they're retaining, meaning that they're not doing a good job breathing out this bad gas, and they're doing it for long enough, the CO2 levels in the blood start to rise, and that can also let us know when it's time to intervene. So how do we treat it? Well, if the adenoids or tonsils are enlarged, we can recommend removing them. And even though that there are other levels of obstruction, and this might not completely fix the sleep apnea or fix the breathing, even if the child still needs some help with some BiPAP after, it will allow us to use much lower pressures and make the BiPAP much more tolerable and more comfortable. I talked about those arytenoid cartilages falling into the airway. So there is microsurgery that can be done that helps kind of spring them open. This works really well in neurotypical children. It unfortunately does not work that great. There's about a 70% failure rate in neurologically impaired children. And it's primarily because very often they have laryngomalacia where these arytenoid cartilages are falling in because it's the downstream effect of the other levels of obstruction. So even if you spring open that voice box, but they're still having pharyngeal collapse, they still have large tonsils, they still have large adenoids, that voice box is still going to fall into itself. So really the mainstay here is BiPAP. And so what BiPAP is it's bi-level positive airway pressure. And we prefer bi-level pressure over single level, which would be CPAP, because of the underlying hypoventilation and central events that commonly occur in children with neurological impairment. So what it does is, it's a device, and this is, and he's wearing it. And we don't like at home to cover the whole face or the nose and mouth in case your child retches or vomits in the middle of the night, and also because many of these children can't communicate or can't rip it off. And so we want to, be as safe as possible. So we usually only recommend covering the nose. And so what it does is with pressure, it forces air into the airway, more pressure on the breath in to really open up those structures that are collapsing in the upper airway so that their breath in is more effective and they get all the oxygen that they need. And even on the breath out, we maintain a little bit of pressure because remember, the airway's more floppy because of the tone, the muscle tone. And if they need oxygen in addition to that, it can be bled into the device as well. But usually this is done with just room air and some pressure. And some children, their neurological impairment does progress or their lung disease does progress and they do need a tracheostomy. And this is always, a very difficult, psychological and ethical decision that is really made on a case-by-case basis, together with the family if it's necessary. Cough assist device is probably the most important piece of machinery in our arsenal. So this is because these children, yes, your child does cough, but it's usually ineffective because of the muscle tone and because of the low lung volumes. So the cough machine does two things. It provides a massive pressure of air. And so what it does is it really does the job that the muscles are not doing, and it expands that chest wall, and it pushes that diaphragm, and it opens up those lower airways that have become collapsed. And then that allows the mucus then to start moving out of those lower airways, breaking up that atelectasis. And over time, what we see with these children who use this every single day is that they go from having lung volumes like this to all of a sudden having normal lung volumes. And it reduces the number of recurrent infections and decreases the likelihood of developing bronchiectasis. Chest vest works in another modality to help clear out the mucus in the airway and break up that atelectasis. My group, we started using this off-label for children with neuromuscular weakness back in the early 2000s. And then in 2014, we conducted the first pilot trial in neuromuscular children, which then allowed chest vests to be approved and covered for children with neuromuscular weakness by the insurance companies. And this was our pilot study data, where you see, I keep pressing the wrong button. It was really that long-term follow-up where we started seeing a trend after the first 6 months. But when we really looked at these children a couple years out, after initiating chest vest therapy, many of them, their hospitalizations dropped significantly. Chronic aspiration. So by the nature of the muscles being weak, a lot of people don't realize we use over 30 muscles to swallow. So when the muscles are weak, they're all weak. And this really impacts that ability to coordinate the swallow and protect your airway. Chronic wet cough is very often the only symptom that you have. A lot of parents will also report that their child just always seems congested, that they feel it on the chest or they have a rattle that just doesn't seem to go away. It gets a little worse if they have a cold, but then it's always kind of there. Then there's the obvious things, right? If they're obviously coughing or choking or gagging with feeds. But sometimes those symptoms are absent, and we can have what's called silent aspiration. Or your clinician might hear this persistent wheezing or crackling on the chest, or even wheezing or crackling that tends to come and go, but they're hearing it often enough that they're like, what's going on here? And as I mentioned before, having the absence of certain clinical features shouldn't make you rule out aspiration. These children often never have fever. They have a normal chest x-ray. They may not have obvious signs when they're eating and swallowing of aspiration because it can be silent. And this is microaspiration. So yes, if you choked and swallowed some massive piece of food, you're going to have pneumonia and you're going to get a fever and you're going to be obviously sick. But if you're just aspirating little drops over time, the infection is more localized and you're not going to have changes on blood work and you're not going to develop fever and you're not going to develop changes on chest x-ray. So there's several types of aspiration. I hope this works. Let's see. It does. All right, so we have our child, and you have the stomach where the food should go, and you have your airway. So normally when we feed, it goes into the stomach. But not every swallow you're necessarily going to aspirate. You may have a couple swallows that go where they're supposed to go. But then you have that one swallow during that whole meal that goes in the wrong spot. And this we call aspiration from above. You can also have contents in the stomach. This doesn't have to be food. This can be the saliva that you swallow. Many of these children have trouble managing their oral secretions, okay? This can just be the gastric contents in the stomach. And sometimes it comes up and refluxes over into the airway. And this is aspiration from below. You can also have some anatomical problem that allows for a communication between the airway and the esophagus. Most often in neurologically impaired children, this is more an anatomical problem with the vocal cords, where you do swallow, but then the food still goes in the wrong spot. And this is aspiration from an anatomical issue. So as I've mentioned before, it's about the accumulative damage from the aspiration. We all aspirate. We all aspirate in our sleep. We all aspirate from time to time, and I'm sure everyone can think of a moment where you've swallowed something down the wrong pipe. But our respiratory system has protective mechanisms. we have an effective cough to clear our airway and to clear whatever we swallow down the wrong pipe out, okay? We also have ciliary clearance. So your whole airway, from your nose all the way down, is lined with microscopic, what I kind of like to think of like windshield wipers, that move in a coordinated fashion to help clear the airway. We also have macrophages. So macrophages are an immune cell. I like to think of them as Pac-Man. So you swallow something into the airway, and Pac-Man macrophage comes along and eats it up and then manages to clear it out of the system. But if you're having microaspiration over and over and over and over again, it eventually overwhelms all our protective systems. And when you're aspirating, whether that's coming from below or coming from the mouth, our whole GI tract has different bacteria that make up the natural biota than our airway. And the bacteria that lives in our gut and our mouth doesn't belong in the lungs. And it doesn't do well there. So when it's entering the airway, because we're aspirating, you eventually get overgrowth of that bacteria. And that bacteria is most problematic for the ultimate development of bronchiectasis. And there's been a lot of really interesting work over the last couple of years showing that bronchiectasis actually develops very, very rapidly in children with neuromuscular weakness. Cincinnati Children's did a study a couple of years ago where they took the first 100 patients that walked into their aerodigestive center. And of that 100 patients, 15 of them had neuromuscular weakness. And all 15 of them, and they came to the aerodigestive center for complaints of cough. That was the only symptom. They all got CT scan, and all but one had already, in less than 6 months of having the symptom of cough, had developed bronchiectasis. So this usually comes along what we call suppurative lung disease, which is bronchitis, so a local infection in the breathing tubes with pus, thick pus, and I'll show you what that looks like. I know, a little difficult if you've had a snacker. So you get aspiration into the airway, and what you usually develop is purulent bronchitis. You can get aspiration pneumonia, but it's less common actually. You have ineffective cough, which impairs your ability to clear those secretions. You have chest and airway deformities, which also impair your ability to clear those secretions. And when you can't clear secretions in the airway, you develop bronchitis. So these are all the pathways where we end up with bronchiectasis. So really how we assess, we talked a little bit before in the last study about swallow study, but what we like to do is really look and get a sample of the mucus with a flexible camera in the airway, because we can tell you, is there a bacteria down there, and if it is, what is it, and how do we treat it, and how do we prevent it? Is there food getting in the airway? And this is what it looks like in a child who's been aspirating, and the only symptom was cough. So in summary, children with FOXG1 who have significant neuromuscular impairment, we suggest would benefit from long-term pulmonary follow-up. That upper and lower airway endoscopy is a very useful tool to help diagnose the problem and to help develop individualized treatments for your child. That we recommend a baseline sleep study. There is a lot of evidence out there in neuromuscular impaired children that they really should have a baseline sleep study every 2 years at least, or more sooner if there's symptoms. And this is because when the muscles are weaker, those usual signs that your child is having trouble breathing, you and I don't see because they're not breathing in the same way. And so the sleep study is really an objective measure of how well they're breathing at night. Use of BiPAP when it's indicated. The sooner you initiate BiPAP if it's indicated, the more that you slow down the progression to chronic respiratory failure. the aggressive use of lung recruitment with chest, vest, and cough assist, and a swallow evaluation to assess feeding and determine appropriate strategies to prevent that aspiration. Thank you.
Thank you so much. So I'm sure you could see why I said I need you to explain all of this to our whole community. So we're going to do Q&A now, and then just a little change in the schedule before we have Dr. Romans, who actually couldn't be here in person, and she took your questions and answered by video, so she won't even be live because she had to do a last-minute travel. So we're going to take a break after questions and then come back and see Dr. Roman's video. But first, Ryan, did you have a question?
I have two. One is, my son, and I suspect many, have a very narrow airway.
Yeah.
They weren't breastfed, or they breastfed very little amount of time to widen their palate, didn't widen their palate. And then they also are chewing, right, to help with kind of that structure to build the palate wide. What do you recommend to is there anything that can widen the airway of these children later in life? Orthodontics, I know for adults, typical adults works. I don't know about neuro.
So there's been some people looking into using dental devices to sort of help prevent, sleep apnea issues. This tends to work better in neurotypical adults who snore to help open up the airway so they stop snoring and waking up their partner at night. But you've got multiple levels of issues that impact the breathing. And so typically these orthodontic devices don't really work so well. Certainly if there's surgically correctable causes of, that are impacting the airway, that's one way that you can get sort of more room there so that they breathe a little bit better.
And then my other one real quick is whimpering. I would say my son every so often whimpers in his sleep is how I would describe it, kind of in like a type of thing. What do you think that is?
It may be difficulty breathing at night. We see a lot. Very often we get some children, their sleep is disrupted, right? And it can be disrupted because of those neuron pathways and the hyperalgesia that very often comes along, but it can also be disrupted because they're trying to breathe. And so some kids will just frequently wake up crying at night. They have that whimpering or that weird sort of gasping noise. So it's worthwhile investigating it. It doesn't necessarily mean that it's absolutely sleep apnea or hypoventilation, but it may be, and it's something worth looking at.
So we try not to have too many, tests and studies done because it's never nice for the kids. So we try to get the most information out of the studies we do. If you do the study where you use the camera and see what's going on, would you then still need a swallow study afterwards, or would that kind of already, give you the same result but show you more than a swallow study, or would you recommend both?
They give you very different information. So in terms of the swallowing and the aspiration, when you're looking with a camera doing a laryngoscopy, bronchoscopy, you're looking for a couple of things. One, you want to see, is there an anatomical reason why this child aspirates? And is it an anatomical reason that I can intervene on? So are the vocal cords not able to close and protect the airway? Number one. And that's going to guide your treatment for that aspiration differently than if there is sometimes some children at the bottom of the vocal cords will have sort of a notch or a groove. So they might be doing all the things they're supposed to do to swallow and protect the airway, but they've got this little opening and everything's just slipping in. And that's something that can be intervened on. You also want to know, is there evidence that there's food getting in the lungs? And is there infection there? And how do we treat that? Because usually the bacteria that comes along with food does not respond to antibiotics in the same way. You can't eradicate it from the lungs. You can treat a flare-up of it, but you can't get rid of it. And so there's preventative treatments that you need to do long-term to keep it down. The swallow test actually shows you at what point in the swallow is impaired, and where, and how much and how often. Are they just penetrating but then able to clear? Is it going all the way down? Is it coming? You can also do a test through the G tube as well. So are they aspirating from below and it's actually not coming from above? So they're complementary. They give you two very different types of information.
Hi. I'm going to totally butcher these terms, but I'm going to go ahead and try.
Go.
Okay. So my 1-year-old daughter was diagnosed with sleep apnea, and her pediatric ENT were 3 weeks post-op, did a supraglottoplasty
Yes.
and an endoscopic arytenoidectomy.
Yes.
Okay.
You
so-
actually, that was beautiful.
Oh, thank you. Okay.
Better than I can say that word, actually.
So my question is, how long after surgery do you typically expect to know whether it was a success or a failure? And have you ever seen it where it looks successful and then down the line it becomes something that's no longer helpful with sleep apnea?
Yes. So usually we like to wait about 6 to 8 weeks before we repeat a sleep study to see how effective it was, to see does your child still need some support at night, or did it, address the sleep apnea enough that, for the next year or 2 years or until there's symptoms again, we can forego using anything else. Sometimes because if there is some progression in the neuromuscular weakness, that things can be really good for a period of time, and then they're not. Or if your child unfortunately gets sick and gets hospitalized or has an increase of seizure activity and they're just weaker for a period of time, sometimes the symptoms can worsen again. So, the child's always the boss, right? And we use them to help us know when we need to test again.
Okay.
We have time for one more.
So our situation's a little bit different because our son's adopted. So I think very early on there was a pulmonologist involved in his care, but in the 2 years that we've had him, we have not had a pulmonologist on our team. So is it something that we should have? And if so, what information should I take to them to justify getting someone on our team? Like, the only issues that we really have is if he gets like postnasal drip. He has a hard time getting that up sometimes. And that can go on for like a week, but it's not something that's chronic. It's not something that's there all the time. So I tend to get people on our team and then just kind of have them.
Mm-hmm.
But I want to know if that's like the best thing to do, to have someone before things get to a point where it's an emergency, or even until we absolutely need someone. So that kind of.
We always like to, so the biggest judge too of how much your respiratory symptoms going to be impacted is if your child is able to get into a seated position by themselves and stay seated upright, and if your child's walking. So if those things are impaired, it's always a good idea. Like, we have children who have neurological impairment, but we see them once or twice a year because they're doing well, and we're not at the point that we need to intervene, but we know about them. We're in touch with their neurologist and their other team members, and we've at least met them, and so that way when you call because something has changed, I can get you in right away. I already know your child, and I'm going to be like, yeah, I agree, this is definitely different from their baseline. So there's nothing wrong with having somebody on board that maybe you only touch base with once a year until you really need them more often.
Thank you.
So very often with neurologically impaired children, there are no symptoms, okay? So, we do generally at a certain age, once they're beyond the age of 4, at least get one baseline sleep study.
Thank you so much.
Thank you.